My name's Jestin Carlson. I'm the Program Director of the AHN St. Vincent Emergency Medicine Residency and also the Associate Chief Medical Officer at AHN St. Vincent. In this module, we're going to talk about cardiac arrest, and I have no conflicts of interest to disclose. Let's start with a sample case. This is a 72-year-old female who has a cardiac arrest. Now, what would we want to know with this? Let's talk about downtime. We'll talk a little bit about bystander CPR. We might want to know what initial rhythm she presented with. We also want to know defibrillation and if that was attempted, and if so, how many times. Was any definitive airway attempted? What other comorbidities does she have? Now, also, we'll look at overdose potential. We'll talk a little bit about some of the medications that might be administered in a situation like that. And we would also want to get a glucose on this patient. So some specific questions that we'll look to answer during this module on cardiac arrest are first, how fast should I compress? Next, how deep to compress? The third question that has been examined multiple times with several different medications is, what medication should I give, if any, in cardiac arrest? If you get ROSC in a patient like this, what should be done afterwards, including, should we cool the patient? If we do get ROSC, what blood pressure should we shoot for? And then last, should we do any additional tests to help better identify either prognostication or identify causes of the cardiac arrest? So just to make sure we're all on the same page, there are several terms that are used during cardiac arrest, and just want to be clear about the definitions of each of these. On the far left-hand side, you have VT, which is ventricular tachycardia, VF, ventricular fibrillation, PEA, or pulseless electrical activity, and then finally asystole. Now, some of these have more organized electrical activity, some of them are shockable, some of them are not shockable. And so just to, again, make sure that we're all clear about the definitions, here is an unorganized rhythm. This here is ventricular fibrillation. Now here we have an organized rhythm, but with no pulse associated with it. This would be an example of PEA. Here we have no identifiable electrical activity. This is asystole. And here we have an organized ventricular beat. This would be ventricular tachycardia. Also, just to be clear on the definitions of the outcomes in cardiac arrest. So there are several different outcomes that we're going to talk about during this module. The first is ROSC, or return of spontaneous circulation. That's when we get a pulse back during the resuscitation efforts. SDH is survival to hospital discharge, and FNS, or functional or favorable neurologic outcome. In that situation, we're looking at an individual who not only survives the cardiac arrest, survives the discharge, but survives in a way that they are able to go back to many of the activities that they were able to do beforehand. In the United States alone, there are over 400,000 cases of cardiac arrest annually. And unfortunately, the overall survival, especially from out-of-hospital cardiac arrest, is low at around 8%, although there is some variation around that number. There are several factors that are associated with better outcomes, including if the initial rhythm was shockable, if there was early CPR, and, back to the shockable piece, if there's early defibrillation. And so it's really important to be able to help provide care for patients in cardiac arrest early. In other areas, such as trauma, we've talked about the golden hour, but really for cardiac arrest, it's the first 10 minutes. This graph here shows the probability of survival as a function of how quickly EMS can get to that out-of-hospital response. In the best case scenarios, even when EMS is right on scene, really, we're still looking at about 6 minutes from when the call goes in to when our paramedic colleagues are able to arrive on scene and take over the care of the patient in cardiac arrest. By that point in time, the probability of survival is already down to 10%. Now, as I did mention, there is wide variation in the rates of survival, whether you're in Seattle or other areas, so there is some geographic difference in terms of survival. But there are lots of things that can be done that we can do to help improve those chances of survival. Many different approaches to cardiac arrest have been proposed over the years. We're going to talk about the latest evidence supporting CPR with early defibrillation and the compression and appropriate depth for CPR. But many different things have been proposed over the years, including rolling people over barrels, putting them on the backs of horses, flogging individuals, trying to breathe into their mouths, and even trying to breathe into the other end, which leads to a lot of different questions about what what led to these individuals to select those approaches to help patients in cardiac arrest. But right now, with the best evidence that we have, true or false, we should push hard and fast. That's how you improve outcomes. And that is true. This has been looked at multiple times over several years. The ideal rate is somewhere between 100 and 120 compressions per minute with a depth of about 2 inches. If we start going faster than that or slower than that, that starts to impact outcomes and patients do not do as well. If we compress too much or not enough, that also impacts patient outcomes. So we really want to shoot for that rate of 100 to 120 and a depth of about 2 inches. Now, the other thing that's really important is to make sure that we do not overventilate patients in cardiac arrest. This is something that often happens, and it's really important that we try to minimize the ventilations. We're really shooting for about 1 breath for every 6 seconds, or about 10 breaths per minute. And for those of us in the emergency department, in the ICU, on an ambulance, it's really important that we watch whoever is providing bag valve mask ventilation or ventilation through something like a supraglottic airway or an endotracheal tube to make sure that we're keeping that rate slow. One of the things that's really important while we're performing CPR is to minimize pulse checks or pauses. Data looking at this have shown that there are multiple pauses that occur during cardiac arrest, and sometimes those are for prolonged periods of time, sometimes several minutes. It's important for us to remember to resume CPR immediately after defibrillation and to not pause for a pulse check right after defibrillation. We should avoid pauses for different procedures such as central lines and especially for airway interventions such as intubation. And the reason for that is that we want to maintain a compression fraction of over 80%. That means of any given minute, we want to be doing CPR greater than 80% of that time. That is directly related to survival. And what happens is with that chest compression, with that compression fraction, we're able to develop a good pressure in the vasculature. And so whenever we take breaks, that pressure drops. That's the image on the top there labeled A. Our perfusion pressure drops whenever we make those breaks in CPR. When we can maintain that and have a chest compression fraction of over 80%, that's when we maintain great perfusion. Now, more recently, there's been multiple studies looking at the value of a CPR coach, someone who actually monitors the individuals performing CPR, ensuring appropriate rate, depth, and that we're not having those long pauses for procedures or for pulse checks. While the data are mixed, there are some data suggesting that this may help, especially in cases of pediatrics, although they've not necessarily shown improvement in patient outcomes, but have shown that we're as individuals able to better adhere to guidelines about the recommended rates and depths, which those rates and depths of 100 to 120 for a rate and a depth of 2 inches, those have been able to be associated with improved outcomes. So let's talk about a couple other areas that come up when we talk about cardiac arrest. True or false? Compression devices are better than manual CPR in terms of, and this is the acronym we talked about a little while ago, FNS, functional or favorable neurologic status. Well, unfortunately, the devices, while very good, are not necessarily better than our hands. They do offer some other advantages where they can allow individuals, especially if there's a limited number of team members, to be able to perform CPR. They do allow team members to be able to go and do other tasks during the resuscitation, but they've not necessarily been shown to improve patient outcomes over manual CPR. True or false? Epinephrine improves functional neurologic status. Unfortunately, this is false. There are multiple studies that have looked at epinephrine that show that it may improve the rates of return of spontaneous circulation and admission to the hospital, but not necessarily great data that epinephrine improves what we would ultimately want from our patients, which is a favorable neurologic outcome when they're discharged from the hospital. Just in looking at a couple of other medications, amiodarone, true or false? It improves functional neurologic status. Unfortunately, that's false. In a large study looking at amiodarone, lidocaine, or placebo in patients without a hospital cardiac arrest, neither amiodarone nor lidocaine improved patient outcomes over placebo. Now, some other data recently has looked at calcium in terms of FNS. And this is something that has been advocated for multiple times in the past, and there are specific conditions where calcium makes great sense as a treatment recommendation in patients with cardiac arrest. Specifically, those who suffer a cardiac arrest because of end-stage renal disease and hyperkalemia. In those instances, calcium is definitely indicated and can improve their outcomes. But as a routine treatment, a large prospective study looking at the use of calcium versus placebo actually showed worse outcomes in terms of favorable neurologic status in the group that routinely received calcium. And so, should calcium routinely be used in out-of-hospital cardiac arrest or in the treatment of patients with cardiac arrest? The answer is no. We don't have good evidence that it improves outcomes if given routinely, and there is evidence to suggest that it may harm patients. Again, there may be a subsegment of patients with end-stage renal disease and hyperkalemia. Those individuals should receive calcium as a treatment for the hyperkalemia. But as a routine medication for cardiac arrest, calcium really cannot be recommended at this time. Now, something else that's come up recently is the administration of Narcan in out-of-hospital cardiac arrest. Annually in the United States, over 100,000 individuals die as a result of overdoses, and so there is a strong theoretical advantage to administering Narcan in patients with cardiac arrest. There are a couple of studies that have recently been published that have looked at this. No prospective studies, but some observational and retrospective data finding potentially an association between Narcan use and outcomes, improved outcomes in patients with cardiac arrest, although there's a lot of confounding in those individual studies. Specifically, when looking at patients who received Narcan, we don't know why they received Narcan and other patients did not receive. These studies are not prospective randomized trials, so there may be some confounding by indication whereby the providers who are taking care of the patients felt that Narcan may be appropriate in those cases and administered it when they clinically felt it would be valuable. So where does that leave us right now as far as Narcan in the treatment of patients with cardiac arrest? We don't have evidence that it should be given routinely, meaning should not be given to necessarily all patients who are in cardiac arrest. However, the studies do suggest an association between Narcan administration and improved outcomes in patients with cardiac arrest. So in these situations, it's valuable for us to use our clinical judgment to determine if we believe there could be an overdose contributing to the cardiac arrest. And in those situations, there may be advantages to do that, but larger studies and prospective randomized trials are needed to really determine the ideal population for Narcan in cardiac arrest. So really, in looking at the totality of the medications, no single medication improves survival to hospital discharge or favorable neurologic outcome, although epinephrine does help to improve rates of return of spontaneous circulation, so may help to push individuals in that direction. So the routine medications, really vasopressin, magnesium, fibrinolytics. We mentioned amiodarone, lidocaine, certainly calcium and Narcan. There's not great evidence that these should be routinely given in cardiac arrest, although you may use your clinical judgment to determine if things like Narcan or calcium in the example of hyperkalemic cardiac arrest may be valuable. So regional practice would still include epinephrine and may even include bicarb to help with the acidosis that can develop as a cardiac arrest becomes prolonged. So let's move beyond the moment of cardiac arrest. We've done great CPR. Maybe we've provided early defibrillation if they had one of those shockable rhythms that we discussed early on. And now we have success. We have return of spontaneous circulation. Where do we go from here? So the first question that is still circulating around is, should we cool the patient? Should we provide therapeutic hypothermia? And true or false, does hypothermia improve favorable neurologic status? Well, several years ago, there were some very large trials that came out in the New England Journal. 2 large trials that actually showed improvement in that functional outcome for patients who were cooled after their cardiac arrest. This provided a lot of excitement around this as a possible modality to help improve survival for these patients. Both these studies were small, though. And over the last 1 to 2 years, we've really had some very large trials that have tried to replicate those results. Multiple other trials have come out and unfortunately have not been able to replicate those results. The largest of which was TTM, or Targeted Temperature Management 2 trial, which came out in 2021. This compared patients who received hypothermia with a temperature of 33 versus those who were at 36 degrees and did not find any difference in mortality, favorable neurologic status, or any of the other major outcomes that they looked at. Unfortunately, several other areas have also been looked at and have not found therapeutic hypothermia to really be of a great benefit in this patient population. That includes in the pre-hospital setting, also in the in-hospital cardiac arrest setting. And so the big take-home from many of these has been to avoid fever. Definitely when our patients develop a fever after cardiac arrest, there is significant evidence that they have worse neurologic outcomes in those situations. So while cooling may not improve outcomes, preventing fever can prevent the harm that comes along with an elevated temperature after cardiac arrest. So as a result of these data, the American Heart Association provided an updated expert opinion in 2023, really stepping back from therapeutic hypothermia and instead advocating more for the prevention of fever. The International Liaison Committee on Resuscitation also echoed these findings by stepping back from therapeutic hypothermia, and even the terminology around this has changed. So instead of therapeutic hypothermia, the terminology then changed to targeted temperature management, which has now changed again to temperature control. We really want to try to prevent fever in these patients. We don't need to cool them anymore, but we want to help control their temperature around normal physiologic temperatures. The next question that often comes up is true or false? Higher blood pressure improves outcomes. Now, we do start to have some data around this to really help us better answer this question. Should we squeeze those pipes? Should we try to get the mean arterial or MAP pressure greater than 70? Might that help to improve cerebral perfusion and really help to improve neurologic outcomes? Recently, a systematic review and meta-analysis was performed that identified 4 studies actually on this topic, 4 prospective randomized control trials examining this question about a higher MAP versus a lower MAP. And unfortunately, there was no benefit in the patients that received a higher mean arterial blood pressure relative to those who had a MAP of 70 or less. This doesn't tell us the exact mean arterial blood pressure to shoot for, but it does tell us that focusing on getting the MAP greater than 70 as a routine clinical practice in patients after they get return of spontaneous circulation really is not something that we need to be doing right now, and our efforts may be better focused elsewhere. Last question is, okay, so we have somebody after cardiac arrest. We've said that we don't need to cool them. We don't need to focus on getting their blood pressure with a MAP greater than 70. What about additional tests to look for the etiology of the cardiac arrest? So true or false, CT scans are useful in determining the etiology of the arrest. Multiple different studies have looked at this question, including some older studies that were retrospective and some newer ones that are prospective observational studies looking at the value of CT utilization in patients after cardiac arrest. One thing that is clear from these studies is that the CT scan does help us identify multiple different causes, potential causes of cardiac arrest, but also injuries that could have been caused from the resuscitation, such as rib fractures, pneumothoraces, and liver lacerations. One thing that's not clear, though, from these studies is that there's any improvement in outcomes, including in the prospective studies looking at this. Even in those data, there's not a clear signal that there is an improvement in outcomes when we obtain the CT scan. This may still become part of your institutional protocol to do this, to look not only for potentially reversible causes of cardiac arrest, but also to identify potential injuries from the resuscitation. But right now, as a matter of routine, do all patients who suffer a cardiac arrest need to have a CT scan? The data doesn't support that. So in answering our questions from the beginning, how fast should we compress? 100 to 120 compressions per minute at a depth of about 2 inches. While multiple medications have been looked at in cardiac arrest, epinephrine is a reasonable medication to administer, although the routine use of calcium cannot be recommended at this time. There may still be cases where calcium is valuable, specifically hyperkalemic arrests in patients with end-stage renal disease. As far as therapeutic hypothermia or temperature management, we really are not cooling patients anymore, and at this point in time, it's best to avoid fever in those individuals. If you get ROS, should we shoot for a higher blood pressure? Not routinely. There may be clinical indications for that, but as a matter of routine in patients with cardiac arrest, we do not need to adjust the mean arterial blood pressure to greater than 70. And any additional tests. While the CT scan may be valuable in certain situations, this is an example where we can use our clinical judgment to determine when we believe a CT scan may be indicated in those patients. Thank you.